Our panel is Graham Parsons, our Chief Pharmacist and Hepatitis C lead at Turning Point, Beverly Edwards, Specialist Hepatitis C nurse at St George's Hospital, and last but certainly not least, Paul Huggett, our Hepatitis C Trust Peer Support Lead for Leicester. Okay, so without further ado, let's get on with the questions. We've got a lot in quite a short time. So, Bev and Paul, this first one is for you. What does treatment for hepatitis C consist of?
Do you want me to go first, Paul?
Go for it, Bev.
So the treatment for hepatitis C has evolved an awful lot over the last sort of 7 to 10 years. And basically, it's all tablet now. There are no treatments that we use interferon, so we don't use any injecting with hepatitis C patients at all. The treatments are usually between 8 and 12 weeks. We still have a tendency in the service that I work in to use genotype-specific medications, but that's not always necessary, depending on the client, depending on how and where we see them. We have what we call pangenotypics, which are drugs that can be given to almost anybody, and they have a very, very low side effect profile. Generally, they don't come with any problems whatsoever. We can dispense them on weekly, fortnightly, even daily dispensing. So treatments are very much sort of adapted to people's lifestyles. They can take them with a methadone or if that's what works for them, and they tend to be very short, very effective, and very easily to tolerate.
Brilliant. Thank you, Bev. Paul, could you add some about your experience of Hep C treatment?
Yeah, no problem. My experience of Hep C treatment, I've had hepatitis C myself. I found out in 2003 and I did interferon and ribavirin, and I did a year long and it was absolutely horrific. It wasn't very nice at all. And now I have the pleasure working for the Hep C Trust of supporting patients through treatment, and it's basically a simple course of tablets, 8 to 12 weeks depending on which tablets you're on, and side effects, really, I've put hundreds of people through. The only one I've known of, well, we've had one who had to be changed meds, but the only other one I know of is the odd headache, and if you take the paracetamol and drink water, it goes away. So if you think how far it's come from what it was to what it is now, it's just unbelievable, you know, and it is a worry and a fear when you find out you've got hepatitis C, and there's a lot of myths and stigma. So the reality is, if you use drugs like I use drugs, you're lucky if you don't get it, you know. So, but it is a simple course of treatment, and yeah, it's really nothing to worry about as long as you identify the people who have got it and get them on treatment.
Great, thank you. Next one's for you, Graham. Just a quick question here. How successful is treatment for hepatitis C?
Thanks, Becky. Yeah, and thanks for inviting us on today. Yeah, the success rate for hepatitis C treatment is amazing, and this is, I suppose, one of the reasons that certainly we're pushing for clients to come onto treatment. Bev and Paul have already talked about the kind of simplification of the treatment regimes, and also the fact that we've gone from injections from previous years to oral medications now. And, you know, I mean, the success is really high. We're talking about 95% plus. And if depending on which reviews you look at, you know, some report 98 to 99% success rate. So we're talking about a highly successful course over a short period of time to eliminate hepatitis C, which is absolutely amazing. And even in the worst estimates, you're talking about a success rate of 19 out of 20 people. And, you know, I mean, a lot of the literature now even supports a higher success rate. So it really is very successful. Minimum time in terms of the intervention, oral treatment with minimal adverse effects. So it's really something that we need to be pushing for.
Okay, brilliant. Thank you, Graham. Carrying on the theme of treatment, Bev, this next question is for you. It says, I've been treated for hepatitis C before. Can I catch it again, and can I be treated again?
So, yes to both of those questions. What you cannot do is, if you have had successful treatment for hepatitis C and you have cleared the virus, and by that I mean you will have to have a test 3 months, a capillary blood test hopefully, or a blood test depending on which service you attend, but we have to have a negative PCR test or a negative test 3 months post-treatment or around about that time. So from the date that you completed the treatment, we have to do a test at 3 months to ensure that the virus is not detected. If the virus is not detected, that means that you've cleared the virus. You could then subsequently go out the next day and catch it again, but that will be a new infection. If you don't complete the treatment, there is a possibility that you can relapse or that the treatment doesn't work, but that's different. That means that's the same virus that you had initially that basically and simply hasn't been cleared the first time round. So you have to have a negative test. It might be a different strain of the virus. You might have genotype 1 the first time round, you might have 3 the second time round. Irrespective of any of those, we can retreat you. And the new retreatment guidelines do not have any jurisdiction on the number of times that you get treated now. We can also now treat people with acute infections, which has now been approved by NHS England, which we weren't allowed to before. So there are no caveats on not being able to retreat people. As I say, if you've got the same virus again, we can retreat you with other options, but they're all tablets. They have very few side effects, and the success rate, as Graham said, is still well over 95-98%. So it doesn't change anything if you get reinfected.
Yeah. Brilliant, thank you. Another one for you, Bev. So someone's asking, how serious is Hep C? Should they bother being tested and treated for it?
Well, there are two sort of answers to that, really. The first probable answer is that a lot of people live with hepatitis C for a very long period of time and are completely asymptomatic of it. The main symptoms are things that we see people living with every day, which is fatigue and tiredness and brain fog and various other things. And we do see that people who start treatment find that these symptoms, in a lot of cases, resolve very quickly. But people live with it. This is one of the reasons why we want to treat it, is because often it can be a silent killer. So what we tend to find is that the people who are symptomatic of this are people that are generally picked up much further down the line. And in those cases, then they will present with liver cirrhosis. And in this case, it's obviously life-threatening. And it can be very, very serious. So the message that we're trying to get out to people really is to have this very straightforward, very simple treatment, 8 or 12 weeks medication with no side effects as soon as you possibly can, because then the consequences and the problems that can go with liver cirrhosis generally tend to be avoided. So it's a very good thing. And in general, we see, particularly with clients in this group who've gone through the treatment, that they do have very much, their quality of life is very much improved, and they do feel very much better, and it often helps with their recovery.
Brilliant. Thank you, Bev. Okay, so our next questions, I think, are going to be in line with our current times. Unfortunately, COVID-19, naturally, a lot of people are very worried about this. So our next question is for Graham, and it's, am I more likely to catch COVID if I have Hep C?
So yeah, that's that's quite a tricky question, and as I suppose our understanding of COVID-19 is developing as we move on. I suppose having Hep C per se may not make you more susceptible to COVID-19 and actually catching it, but if you have an immune response, if you're immunosuppressed, then the likelihood is that you would be in a position where you may be more susceptible. What I would say, and I think what's important to say here, is obviously having any condition, any serious condition along with COVID increases your risk of a higher morbidity or higher chance that you will become severely ill or in fact die from it. So what I would like to emphasize here is obviously if you have Hep C, or even if you don't have Hep C, it's important to make sure that you're maintaining the good practices in terms of infection control. So make sure that you are social distancing, make sure that you are hand washing at least 6 times a day. Make sure that you wear a face mask. Obviously, there's the regulations now around wearing face masks on public transport and in the shops. But I think as a public, we may move to more common use of face masks as they become more familiar. So I think the answer to your question is, if you're immunosuppressed, there certainly is a risk. A lot of people with Hep C may be immunosuppressed, which may increase the risk. But and certainly try to maintain those social distances and I suppose good practices to try and prevent you getting COVID-19. In fact, before we move on, Becky, I don't know if it's worth passing that to Beverly as well, because Bev's obviously had experience in the hospital environment for this as well.
Sorry, can you, well, is that in relation to whether or not people who've got hepatitis C are more likely to have COVID?
Yeah.
Yeah.
Or, yeah. It hasn't, I think it's at this point in time, it's very difficult. I think there is the only issue that we have tended to see in relation to COVID in the hospital is obviously the homeless populations. So obviously there is evidence that shows that people who have been street homeless and who have multifaceted health problems, including hepatitis C, I think have tended to be more likely to be admitted with COVID in the hospital, and we've seen a higher instance of potentially those picking up COVID. But that's obviously a lot to do with the fact that they've been more susceptible. They haven't been socially distanced, and they haven't had all of the things in place that may well have been able to protect them. From a hepatitis C point of view, it hasn't been something that we have noticed in the general population or people that have been admitted to the hospital as high risk. But as Graham said, what's really important is that we can treat these people as quickly as possible, that they do try and maintain their own health as well as we can, engage with drug services, make sure that they are being screened regularly. A lot of the things that we did when we did testing in hostels and hotels is that we've done COVID testing on a lot of the people and given them as much education as we can. And so a lot of them are very informed about it. You see a lot of elbow pumping when you see people out in community. It's quite extraordinary how well prepared they are and how aware they are of things that are going on around them. But it isn't, to my experience, in the normal population of people that we see with hepatitis C, a higher risk of them catching COVID now.
Brilliant, thank you, Bev. Another one for you, Bev, actually. This person said, I have HIV, will this make hep C worse?
The short answer to that is it can do, yes. There is evidence that shows if you are co-infected with both viruses and they're both active, that this can speed up the rate of you getting cirrhosis of the liver. If your HIV is well managed, then generally not. It generally tends to be something that doesn't exacerbate the virus. But with the new treatments that we have for hepatitis C at the moment, they can be used alongside HIV. And ironically enough, I'm going to a clinic this afternoon where I'm seeing a client who is co-infected with HIV and hepatitis C, and we're endeavouring to start them onto direct-acting antivirals today because we can manage that alongside their antiretrovirals. So untreated, yes. Treated, definitely doesn't have any detrimental effects.
Thank you very much, Bev. That's made things much clearer. Thank you. Okay, so Paul, the next one is for you. More of a statement than a question, but still very, very relevant and important. It says, I think I have hep C, but I'm scared to tell anyone, even my doctor, in case they judge me.
I think that's how a lot of people feel when they find it, you know, when it's fear, isn't it? That's what it is. It's lack of education. And one of my big parts of mine is educating people, and that might be drug services and service users. Really, I'd just go and get a test, you know, go to a doctor, get a test, ring the Hep C Trust. And the beauty of the Hep C Trust is most people that work there have had hepatitis C. So we've got a real good understanding on it and how we feel when we think we might have it. So there's a good thing to reach out to. Reach out to the Hep C Trust and they'll sort you out.
Thank you, Paul. Yeah, definitely.
Just to say that, sorry to interrupt, but one of the things that is really probably relevant with Paul to this client is that we work really closely with peers. And they are absolutely instrumental and phenomenal in this area. They will work really closely with clients, even clients who are particularly nervous or frightened, because they have such personal experience and such personal insight into doing this. And a lot of the times they will engage with the clients. They'll have long conversations with them before they even get to the point where they're ready for treatment with us. So that support is invaluable, and you find that this is becoming more and more as we're getting to people who are much, much more reluctant to perhaps engage with us or with services. The peers are that conduit between the two, and they have a very, very, very big role to play. So they're the people that who are frightened to ask whether or not they've got Hep C and have a test, are the people who really facilitate this in the most important way.
Definitely. Okay, so let's move on to the next question. So this one's for you, Graham. My housemate has Hep C. Can I catch it?
But the short answer is yes, but it's quite difficult. I mean, obviously, the main transmission route is blood to blood. It's a bloodborne virus, and if we look at the UK, about 92% of cases, 90 to 92% of cases are through injecting drug use. And so that is the main, I suppose, push and effort that we certainly would have in the drug service as well, is around harm reduction, looking at move people away from injecting to a safer use of drugs. And if people are injecting, looking to educate to prevent, to obviously prevent the risk of transmission. There are small risks of transmissions for household contacts, but such as sharing toothbrushes, for example, where blood may be on them. But it's a small risk, and it's hard to actually quantify that. So I would say that, while the risk is there, there's no risks around things like sitting on the toilet and, some common misconceptions that have been predicated. The risks are small, and the main risk remains through injecting drug use, where, like I say, 9 to 10 cases are. But obviously, you need to prevent risk of things such as sharing toothbrushes. In terms of drug use, we talk about injecting drug use as well, but even sharing straws, for example, for cocaine use, there is a small risk associated with that. So yes, you can, but the risk is actually very small, and the main route of transmission in the UK is through injecting drug use.
Brilliant. Thank you, Graham. You did actually answer another question there. We had someone ask if you can catch it from changing rooms or loose seats. So thank you for clarifying.
Oh, right. 2 in 1.
Yeah,
to
2 in
off.
1. That goes in nicely for our next question, actually, which is someone saying they've never shared needles, but they still caught Hep C. So how can they protect themselves? That can be you or Bev.
Do you want? Sorry, can you repeat the question? There's somebody concerned about.
I've never shared needles, but still caught Hep C. How can I protect myself?
Okay, so there are various routes that they may well have caught Hep C from. Obviously, the most common way of transmission of hepatitis C is through intravenous drug use, which is the highest population of people who've got it. But obviously, there are other transmissions that people could have got. For example, blood transfusions, which we know pre the 1990s were not screened for hepatitis C. People can have tattoos, which is often the way that people who think that they've never used drugs. The other way that is really interesting is an awful lot of people who may well have only ever used drugs or had any contact with drugs maybe once when they were in their teens. They've never used it. Subsequently, they now live a completely spotless life, but then eventually, through some sort of test that was done through the GP, it's been picked up. So the best way of protecting yourself from hepatitis C is to get it cleared, is to get the treatment and to get a cure. Quite often you find that people, when they start on the treatment within a couple of weeks of taking the medication, are virologically undetectable. And so then they're in the same sort of situation as people who've got HIV, which is if the virus is not detectable, it's not, you can't contract it. Otherwise, it's really just about good health, exactly what we've been having drummed into us in relation to things like COVID, making sure that you protect yourself, protect others around you, never put yourself at risk of anybody with, if you cut your finger or any of those sorts of things, just making sure that you clean things up properly, use alcohol to clean things up or diluted bleach and things. But it's more about protecting yourself by taking the treatment and making sure that you don't put anybody else around you at risk. Do you agree with that, Graham?
Yeah, and I suppose, Becky, we come in here and there's a current debate around alcohol users, isn't there? And screening for alcohol users. So people who use alcohol, the use of alcohol per se doesn't lead to hepatitis C, but there is some evidence to suggest that people who have used alcohol may have hepatitis C, and this may be due to the increased risky behavior, especially when they're younger, which may lead to, I suppose, experimentation with drugs or something that they then go on to forget. So I know we're having this debate at the moment around alcohol use and screening people that have alcohol use disorders. And the prominent thing with that, of course, is if you've got Hep C and you're using alcohol, that can have a very significant impact on the liver. So I think there's 2 cases there around the impact that using alcohol will have on the liver, and also the risk that using alcohol in terms of the risky behavior may have increased your risk to get hepatitis C, especially prior to coming in for testing.
Great, thank you. Just following on from this question as well, they say they've never shared needles. Is it possible that they may not share the needles, but if they shared any other injecting equipment, they could have caught Hep C?
Yeah, I mean, for example, one of the classic ones is just sharing water. So, I mean, even a hepatitis C virus is very virulent, and so you can catch it. So if they have shared water, and even if they haven't shared the same needle, if they cleaned their needle in water and then they inject it up with that water, there are lots of we encourage everybody who comes into the service to use completely and utterly everything of their own, to never share anything at all. You don't know if there's a cut on the inside of your nose, you don't know if there's cuts on the inside of the mouth, all sorts of things like that, which are always a possibility. It is one of those things that is transmitted and it lives for quite a long time outside the body. So there are always risks around any drug paraphernalia or any usage of it that is increasing your risk.
Well, yeah, sorry, Becky. I don't know if Paul wants to, because I mean, Paul's worked with a lot of, as a peer, worked with a lot of people. I don't know what your perspective is on that, Paul.
This is a really, really important point, because the amount of people I work with and support, and they say, I've always used clean needles. I mean, I had a serious drug problem for many years, and we'd go and score wherever we scored, down an alley in a park. Me and my pals, we'd go back to a flat, we'd all have clean pins, but we'd all be drawing water out the kettle, or we'd be sharing filters or spoons. Anything that is shared is a transmission route, so it's really important, even when we get people through treatment, to drill home, the harm reduction and the safer use, because the reality is people are going to use drugs. So we just need to advise them to do it safely, and how not to pick it up again. It's really, really important.
That's great. Thank you very much for really home, Paul. I think that's a really important point. Following on with sort of prevention and harm reduction, we've got a question here, which I think is probably best for you, Bev, which is, I have Hep C, can I have sex?
Hep C is not, the short answer to that is yes. I think that it's probably well known through most people who work in drug service that hepatitis C as a virus is not known to be a sexually transmitted virus. So it's very, very low risk from the point of view of sexually transmission. We generally turn around and just give people normal contraceptive advice, wear condoms, obviously protect themselves. The mother-to-baby transmission is very, very low, and is we very rarely see it. It is not 100% that you cannot transmit it sexually, you cannot transmit it through mother to baby, but it is a very low risk. So the general rules of protecting yourself in relation to sex apply, but from a hepatitis C point of view, it is not a high-risk procedure.
So just to clarify, you're saying that the best way forward is sort of barrier contraception, condoms, that kind of thing? Yeah.
I mean, it isn't passed from mother to baby, and so it isn't one of the ones that if you do get pregnant, it's high risk for that. And the virus itself is not generally passed. It's a very low risk, much lower risk of transmission sexually than hepatitis B or HIV, which are both a higher risk transmission sexually. Hepatitis C as a sexually transmitted disease. It is not often a lot of drug services, a lot of genitourinary clinics don't test for hepatitis C because it's not classified as a sexually transmitted disease.
Okay, thank you very much, Bev. Next one's for you, Graham. I've had a hepatitis B vaccination. Does that mean I'm protected against Hep C?
Okay, thanks for that, Becky. The short answer, again, the short answer is no. So we don't have a vaccination currently for hepatitis C, and hepatitis B does not give you protection against hepatitis C. However, I think it's important here, we've mentioned the broad term of harm reduction quite a few times during this talk, and harm reduction is an important element here as well. So as Bev was talking about HIV, that co-infection with Hep C often leading to worst outcomes. It's similar with Hep B. We don't want somebody with Hep C getting Hep B, and we don't want people getting Hep B anyway. So we would certainly encourage our clients to have the Hep B vaccination. It is part of the Turning Point hepatitis C strategy as well, part of the harm reduction part of our strategy, that clients should have Hep B, and we would vaccinate against it. But it doesn't actually provide protection against hepatitis C.
Thank
Can
you.
I just make a point on something as well?
Yeah, please.
Certainly, Paul.
This is just through personal experience. Anybody who injects drugs or has injected drugs, You know, when they say they've never shared, you know, there's always a question mark there, because for me, you don't just wake up in the morning and know how to inject drugs. Do you know what I mean? The first time, somebody with a drug problem injects drugs, it's usually they've gone halves on a bag and whoever they're with injects, you're a smoker. It's just put your arm out and hope for the best, because you don't know what you're doing. It's a learned behaviour. Do you see what I mean? So anyone who says they've never shared, ask them about their first time. Because you just don't know, you know, you don't wake up and know how to do it. You're shown, you know, you're with somebody who does know for the first time.
And I don't know what Paul's view in this as well. You know, I mean, when I first came into drug services many moons ago, you know, the evidence was that there was a transition to things like groin injecting. It used to be, you know, the research I've read about 7 to 8 years. But certainly recent evidence suggests people are moving to groin injecting very, very quickly, and there's more riskier injecting practices now, which you know, gives you a concern. You know, we look at the shooting up report that comes out annually as well. About a third of drug users get soft tissue infections every year as well. And you know, while sharing has decreased slightly, there is still sharing out there. And as Paul said, I think, you know, we as people move through their drug use history, I think it's quite difficult to kind of judge whether people have or haven't shared, whether it's that individual or whether it's us as professionals. And that's one of the reasons, you know, we promote testing. We promote testing for new clients, and we promote retesting for clients as well on an annual basis. So yeah, get tested. Thanks, Paul.
Thank you very much. Okay, so actually, I think the next question is for Paul. This is, my boyfriend thinks he has Hep C. How can I support him?
Help him get a test. Yeah, take him to your drug service and ask for a Hep C test. That's how you can support him. Bring the Hep C Trust. We'll test him. Support him through treatment. We're blessed at the Trust. You know, we go around, do testing days, identify them. But what we do as a Trust, we pride ourselves on proper peer support. You know, that real support, you know, making sure they get to their appointments. You know, I'll drive them, you know, around here. I'll drive them, we'll get them taxis. Anything they need to get through this, the Trust will do, you know, within reason, you know. We'll do everything we can to help them. So all you've got to do, encourage them to get a test, because it is a simple course of tablets. That's the thing we need to keep it in mind. It's a simple course of tablets. And another thing is, amongst the IV using community, this is very, very common. If you've been using drugs IV for a long time, it's ever likely you're probably going to get it. You know, so it just needs to be spoken about. It's like, you know, things die in the light, don't they? So let's talk about this more and more and more.
Brilliant, thank you. Bev or Graham, do you have anything to add?
Well, I think it's important, you know, as Paul said, you know, the drug service is great. The Hep C trusts are actually amazing to offer this. What I would say is if anybody has any concerns about engaging with drug service or the Hep C trust, they shouldn't do. But if they have concerns around that, they can also access testing through their GP as well. So there is a number of routes to get tested. Obviously, we need to kind of recognise that sometimes there's, you know, sometimes people may still feel a stigma about engaging with drug services. So we just need to kind of open up that and make sure that people are aware they can get tested through their GP practice as well. And hopefully from the final quarter of this year, pharmacy testing will be rolling out as a national program soon. So, you know, we're waiting for that. COVID has delayed that, but we're mindful that will be another route that will be coming through soon. Bev?
The other thing that we've got, sorry to interrupt, sorry, Graham, did you finish? Sorry, I didn't mean to interrupt.
Carry on, Bev.
So we've been doing quite a lot of pharmacy testing anyway, so we've done some pilots in our area. But the other thing is that there's an awful lot more pressure, there's a lot more impetus to basically go out now. A lot of the services have got buses, have got things that we can go out and we can meet people within their own environments. They're safe spaces for them to come in and have a test with the Hep C peers. So they don't even need to go into the drug services. The medications can even be dispensed to them pretty much on the sides of the streets, in all honesty, with the buses and things that we've got. We're going into hostels, we're going into the temporary hotels that people have been put into during the COVID epidemic and actually treating them through those environments and testing them. There's been massive testing events that we've been doing across the whole of South West and South East London, and I know all of Pan London, where people have been going into hotels and hostels and testing people, and I think this is pretty much across the whole of certainly England. And people who've been picked up in those environments are getting access to treatment even quicker than going into drug service or GPs, or certainly not into secondary care. So we're taking all of the testing and the treating out to the clients in their environment, which is facilitating making life even easier for them.
And just another point as well.
Please do,
This
Paul.
morning I've been over in Northampton, started 2 patients on treatment. One of them had wet bloods and one of them didn't want needles because he was worried it'd be a trigger, so we DBS'd him and everything was done by that, and the medications were delivered. Both happy, both happy, started treatments, all good.
Mm-hmm.
Fabulous, thank you. We have only got about 15 minutes left and we've still got a few questions, so we'll crack on with the next questions if that's all right with you. The next one we have is someone who said, I was previously told I was hepatitis C antibody positive. Do I have the virus? Graham, could I get you to start on that one?
Yeah, sure. Well, the short answer is yes or no. Somebody gets infected, the natural course of the disease, you get infected. Once you get infected, there's a lot of obviously talk around COVID at the moment. Your body produces antibodies as a response to the infection. It just so happens with hepatitis C, about 25 to 30% of people with the virus will clear it automatically. So they'll clear it during the acute phase, and they won't go on to what we call chronic hepatitis C. So it's the chronic hepatitis C that you can live with for many years, but can result in some significant diseases such as cirrhosis, such as cancer of the liver, and that's often many years down the line. So if you've had the virus and you've cleared it, you will have antibodies in your system, but you won't actually have a live infection. If you've had antibodies and you've not cleared it, and you've not been treated, then you will have the virus. And in COVID-19, they call it the antigen. So that's the kind of generic term in it. You will have the antigen in your system. But yeah, about 2 out of 3 people who are infected with hepatitis C will clear it automatically before they get onto chronic infections. I don't know if Bev's got anything to add on that.
No, I just think sometimes it can be very confusing because a lot of the time that people will, I don't think an awful lot of people who you speak to quite often who are treated for it and tested for it understand the differentiation between antibody positive and PCR positive. And a lot of people think that once you've had treatment for the virus, it lies dormant. And that it can come back, and I think there are lots of misconceptions like that. And I don't necessarily mean through clients. I think there's a lot of GP services, a lot of people in all services that this cohort of people, or particularly people who've got Hep C, come across, who don't really understand that once you've had the treatments and you've had a test at the end of it to show the virus is gone, that the virus is actually gone. That you will, if you go back to your GP, quite often the GPs will test and they will go, you've got hepatitis C. They haven't got hepatitis C, they've got antibodies to it, but they haven't got active virus. There's a lot of confusion, and the messages can be quite mixed, and people will come back to you in clinic and go, I've still got the virus, and you have to explain that they haven't still got it, they have been cured of it, but they've got the antibodies to it. So I think it's about clear messages and making people, or getting, helping people understand in all of the healthcare professions, not just people who work within drug service, but particularly a lot of the GPs that we come across don't have enough information or enough experience to be able to differentiate between the two. I hasten to add, that's personal experience. It may not be something that you guys see nationally.
No. I mean, coming back there. Yeah. Bev is exactly right. Sometimes the knowledgeable expert client will have more knowledge is sometimes than the healthcare professionals and the drug service team. I mean, part of our strategy is to ensure that everybody has a minimum amount of training and understands it, because it is you know, for a lot of people, when you're talking about antibody positive, PCR positive, you know, we've had a debate, Becky, haven't we, about our services and indeterminate results as well, and understanding what an indeterminate result is, and that people need to be referred for venous bloods for that. So there's a whole gambit of terminology which can be confusing for clients, but can also be confusing for healthcare professionals and social care professionals that work in our service. I don't know if Paul's experienced that with working with service users, peers, and staff and GPs as well.
Yeah, I have, yeah.
Short and sweet.
Can I just go back to the fear, because you said about the person who's feared up of getting tested or anything. Now,
Yeah, of course.
I test a lot of people, and a lot of people are feared up about tests. But I sort of say this, you know, it's win-win. It really is win-win. If you have a test and it's negative, it's a win. If you have a test and it's positive, for me, it's a win, because it's a simple 8 weeks course of treatment and you're done. Instead of living in fear, wondering, have I, haven't I? Have I, haven't I? You know, and then if you leave it a certain amount of time, God forbid, you know, it could lead liver cancer, ultimately lead to death, you know. So get a test. It's really important.
Thank you. Absolutely. So just picking up on your answer there, Graham, you mentioned about chronic infection. So someone has asked, actually, what's the difference between acute and chronic infection? Bev, can I get you to take this one initially?
Yeah, so as Graham's already pointed out, the difference between acute and chronic infections generally tends to be if somebody is infected with hepatitis C and within the first 6 months they clear it themselves, that's classified as an acute infection. And what you'll often see is that somebody will be hepatitis C positive, they'll have a high amount of virus in their bloodstream, and often their liver function tests and things might be affected if you go as far as doing venous bloods and things. But then over a period of time, the body produces its own antibodies and they will clear it themselves. So when you retest them, they will then come back as PCR negative, but antibody positive. If after 6 months, and that's the time limit that is classified that we use, they still have an active PCR or they have active virus in their bloodstream, that means that the virus has then gone from acute to chronic. And in that case, they will never clear it of their own, under their own, without treatment. So you will then need to give them medication in order to treat the virus and clear it. So the main difference between the two is an acute infection is something that is generally a shorter period of time and the body will clear it itself, but a chronic infection, it won't, and it will need treatment in order for you to be able to eradicate the virus.
Thank you. Is there a difference in symptoms?
No, I mean, it can be. I mean, some people can have an acute infection and feel quite unwell with it, but a lot of the people that we see who have acute infections have had no more symptoms than people who have chronic infection. It's just the time frame. Or, I mean, that might well be, other people might have different experiences from that. Obviously, they can be, you know, clinical symptoms that they can have, but then that just depends on how badly the liver is infected and whether alcohol's involved and various other things in relation to that.
Okay, thank you. Graham or Paul, do you have anything to add to that one?
Yeah, as far as symptoms go, the symptoms for hepatitis C is what somebody who uses drugs every day feels like all the time anyway, yeah. So they wouldn't know. Now, a normal person, if they started feeling like that, they'd be straight down to GPs. But when I was using drugs, I always felt like that. And unfortunately, with hepatitis C, by the time you actually really, really do know, you know, you're quite a long way down the line. You know, so really, just get a test.
A lot of the clients will say that the symptoms of hepatitis C, as Paul says, are very simple, are very symptomatic of what people will normally feel anyway, the tiredness, the brain fog, this sheer exhaustion and things like that. But to them, that is just a norm. There isn't a particular flag that, like with hepatitis A or Hep B, where you can have a very profound clinical response to having the virus. Quite often there isn't anything they can put their finger on that makes them feel any different than they did the day before or the day after.
I've got nothing to add. I think Paul sums it up quite well, and I've never thought about that in that sense. You know, people who use drugs feel like that every day. So you know, the one differentiation is to have that test and get that confirmation, negative or positive.
So we've got our last question now, and I think it's quite an important one, given that a large proportion of people with Hep C do use drugs and alcohol. It's do I need to be abstinent from alcohol or drugs to access treatment? Any of you can take this one. All of you?
No. Paul, you start, but from my point of view, no. It has no bearing on it whatsoever.
This has changed just like the medication's changed. In 2003, when I found out I had it, I started treatment in 2005. I had to be 2 years clean before they'd even look at me. You know, so but nowadays everybody can be treated. You know, for me, if they're using drugs every day, whatever they're doing, if they haven't got it, they can't pass it. So everyone needs to be treated.
I think the big difference has been that there were very contributory factors to whether or not we could give people, particularly with alcohol, things like interferon. When we were using the interferon, the ribavirin-based treatments, then there was real issues about whether or not people who had underlying health conditions or people who were heavy alcohol consumers and things could have these medications. And we had to take that into consideration. Ribavirin has its own particular side effects that can be related to that. With the new directing antivirals, because in general we don't have any of those problems, they don't put in the same barriers. Also, we have realised that in order to engage the people that we want to try and clear and treat and give the best health care that we can, we can't segregate. We can't just give people rules and regulations in order to give them treatment, because the idea is that we want to improve their health and their life. And we have to go out to them and accommodate all their very different individual requirements.
And I would just refer to my two esteemed colleagues there. So yeah, no, there is no restrictions. I think, you know, at this point it'd be worth saying as well that, you know, we've got tight timelines. You know, Public Health England are looking to clear hepatitis C as a major public health threat by 2025, and the World Health Organization have got a less ambitious target of 2030. But certainly in the UK, we're pushing to eliminate hepatitis C. As a result of that, there's some quite innovative practice. There's some quite innovative partnerships between pharmaceutical companies, the NHS, third sector, that haven't been in place before. So there is a great desire and push. I think the next challenge, as I'm sure Beverly and Paul would support this as well, is getting over this. It sounds terrible, this COVID hump in terms of re-engaging people back into treatment. And obviously, there's a desire from the ODNs, the operational delivery networks, to do this, and there's a desire from drug services. But you know, we just have to kind of pull it together. And Becky, one of your roles at the moment is trying to do this and trying to make sure the ODNs and the drug services are starting this process again, because certainly at the start of COVID-19, it was the case of you know, everything within the NHS was about COVID-19, and it needed to be, and obviously the barrier there was getting people into treatment, and we are slowly coming back to kind of a business as normal. And so, you know, that is the next challenge, to make sure that people get back in and drug services start working with the ODNs again, and we get back to where we were pre-COVID.
Yes, I think that's absolutely right. I think it's difficult because obviously everybody has guidelines that they've got to adhere to for social distancing and health. We are back into quite a few of the drug services, and clients are coming back in on an ad hoc basis, and we are definitely seeing more of them. And so we're trying to build up the services back up again. And we know it's going to take time. But the other thing that we're trying to do is we're trying to, as Graham says, put out new pathways and new working collaborations to try and perhaps move away from that and go out into communities more than we already do, and engage people who are even harder to treat, because people are apprehensive and very nervous still of going into anywhere. We see this in the hospital all the time. You know, even if we make appointments for people in the hospital, they don't turn up. People are still very, very wary of going to anything, you know, of a healthcare nature. So it may well be that we have to think out of the box and do things very differently on the next stage to try and achieve those aims that, you know, we've been set by NHS England.
Brilliant. So we've only got a few minutes left. So if we'd like to take this opportunity for any sort of final or closing remarks, Paul, do you have anything that you'd like to sort of hammer home or
No, I've got a lot to say. I would just like everybody, to try and speak about this more often, know the facts, so that when people are talking about it, they've got the facts and they know what they're talking about, just to ease the worry and the fears, And then my aim, well, hopefully in the future, that people who do put themselves at risk just come forward saying, I put myself at risk and have a test. That's where I want to get to, So, yeah.
Okay, Graham or Bev?
I think from my point of view, the most important thing that we can do is to work together collaboratively to support each other and to just test. I mean, that's the most important thing. We can't, if we haven't got the information, then we can't treat the people. So it's working together as teams with the peers, with drug services, with everybody, and to try and work in this, as collaboratively we can to give the best opportunities that we can do to the clients to try and get them through treatment successfully.
Brilliant.
Yeah, no, I just agree with Paul and Bev again. It sounds like the 210 election when everybody was agreeing with Nick, doesn't it? Although just keep politics out of it. So I fully support that. I think World Hepatitis Day is a great opportunity for us to have events like this, and it's put us in a position where we have been thinking differently, and we've had to think differently. We're more harm reduction, but we're posting things like naloxone now. We're managing drugs differently, and obviously that's going to make us think about how we manage hepatitis C differently as well. So I think it's important to refocus it on World Hepatitis Day, and this is a great opportunity to do that. And I suppose finally, before we go, I'd like to thank Bev for coming on today, and Paul. And obviously, Bev, we had a bit of trouble prior to starting, but we got there in the end, and I know Bev tried hard to be on that, and which is fantastic. And I'd like to thank Becky for chairing this meeting, especially as we put this on her this morning, and said, Becky, can you chair? So you've done a fantastic job. So thank you for that.
You're taking my job, Graham. I'm meant to be thanking everybody.
No, I'm thanking you first. Sorry, and I'm doing it again. So yes, and I can't wait to meet Bev. I've met the lovely Paul. And I can't wait.
I'm in Turning Point quite a lot, so if you're ever down there, Paul, Graham, pop in and see me. I'm usually around with Suzanne Morgan and Danny and everybody down in Turning Point Croydon on a regular basis. So if you're ever around, pop down. It'd be lovely to catch up.
I'll make Croydon my first point afterwards, and I know we still have to look at capillary testing down there. So and I know Becky's on that at the moment. So no doubt we'll be talking in the future.
Very much sort of. I mean, that's one thing that hasn't sort of been mentioned, but is a really important part of the treatment process that we have, which we're really fortunate with, is that in the service that I work in, we can capillary test, which is a very small prick of blood on the end of the finger, but it actually gives absolutely everything, including PCR and genotype in one sample, and it's processed much quicker than it is with the send away bloods, and it's something that I think we're all working towards across the country to try and use as a standard of care, and I think it's a really important one because it can be used anywhere. It can be used out in the community, it can be used in pharmacy, it can be used in secondary care, it can be used in GP surgeries, it can be used in drug service. So it's a very uniform way of doing things. And even clients who I know, Paul, are very reluctant to have wet bloods are quite happy in the main to just have a very small, almost like a blood glucose finger prick and do a blood sample that way. And they don't have to do anything else then. That's the one and only that they have to do.
The volume's
very effective.
The volume's not as, I mean, it's not much more than you would need for a dry blood spot test. So, yeah.
And it's very simple and very straightforward.
Exactly. So we'll carry on. Back over to you, Becky. Sorry.
Thank you, Becky.
So thank you very much, everybody. You guys on the panel, you've been fabulous. I'm sure any audience members will agree. I wish we could carry on longer. I'm sure you've all got so much more to say. But perhaps, well, certainly next year we can do some more questions and discussions on Hep C, and we'll have more stuff going on throughout the year in all of our services. So keep watching, guys. All right. So thank you to the audience who've watched. Thank you to everyone who's put their questions out. And again, thank you, Graham, Beverly, and Paul.